Robotic-assisted traction closure during colorectal endoscopic submucosal dissection. These are the author's disclosures. Endoscopic submucosal dissection, or ESD, is an increasingly recognized therapeutic modality for the management of superficial neoplasia throughout the GI tract. Nonetheless, ESD is technically complex, often involving lengthy procedure times associated with a steep learning curve and high risk for complications. Effective tissue traction, defect closure are critical components for enhancing the safety and effectiveness of ESD procedures. A robotic gripper system designed to assist with traction closure during endoscopic procedures was recently introduced and approved by the Food and Drug Administration to be used in the esophagus, stomach, and colon. The system comprises of three main parts. The driver unit acts as the actuator for the robotic arm. The controller can be freely detached from the driver unit and operated by an assistant to adjust the movements of the robotic gripper arm. The cartridge of the robotic arm is connected to the driver unit, and the gripper can be mounted onto the distal end of the endoscope. There are two types of robotic arms, one meant for traction and one primarily designed for closure. The robotic arm for traction consists of the following components: the distal attachment that is mounted onto the endoscope, the jaws of the robotic traction gripper, an articulating wrist, an articulating elbow, and the actuating cables that are connected to the cartridge. The robotic arm for closure has all the similar elements but differs on the jaw configuration with the presence of a middle post which enables independent function of each arm for tissue apposition. While the insertion of the endoscope with the attached robotic arms can be performed with caution, the manufacturer recommends the use of an overtube to facilitate its insertion into the GI tract. The motion of the robotic arm are operated with the labeled buttons on the controller. Movement includes opening and closing of the jaws of the gripper. The wrist advance function permits the articulation at the wrist, whereas the arm buttons translate into articulation at the elbow, and rotation permits the robotic gripper to move circumferentially along the tip of the endoscope. In this video, we demonstrate the use of this robotic platform for traction closure during ESD of a large lateral spreading granular mixed lesion in the rectum. A large lumen occupying bulky lateral spreading mixed granular lesion was identified in the rectum extending between the inferior and middle valves of Houston. The lesion was situated primarily in the gravity-dependent portion of the colon. A submucosal lift was first performed along the oral side of the lesion in order to push the lesion towards the anus. Once the mucosal incision was initiated along the oral aspect of the lesion, the circumferential mucosal incision was subsequently completed by repeated submucosal injections and dissections with the high-pressure water jet ESD knife. Part of the mucosal incision and submucosal trimming was performed under saline immersion given the gravity-dependent position of the lesion. Upon completion of the circumferential mucosal incision, the robotic traction arm was attached to the distal end of the endoscope and reinserted into the rectum without difficulty. Using the jaw, the edge of the defect was grabbed and manipulated to expose the dissection plane. The control of the robotic arm was strictly performed by the assistant. As submucosal dissection progressed, the robotic arm was repositioned to allow for real-time traction adjustments to optimize visualization and tension on the tissue, facilitating safer and more efficient dissection. Despite the large bulky nature of the lesion, continuous traction was achieved by repositioning the robotic arm without interfering with the field of vision during ESD. When active risk bleeding occurred, the robotic arm prevented the large mucosal flap from falling and interfering with the operating field, thereby improving exposure and visualization of the bleeding site for precise hemostasis using the coagulation grasper. The final portion of the ESD was achieved by pulling the large bulky lesion towards the lumen and away from the colonic fold, allowing for completion of the dissection with the insulated tipped knife. Completion of the ESD, the dual robotic gripper arm was used to assist with tissue approximation for clip placement. The resected specimen measured 7.5 by 7 centimeters. The total procedure time was 54 minutes. Final histopathology was a tubulovillous adenoma with high-grade dysplasia with negative resection margins. The patient was discharged without immediate or delayed adverse events. There are several potential limitations and future considerations based on our initial experience. For one, operation of the robotic arm is primarily performed by an assistant. The learning curve associated with its operation remains to be determined. Importantly, while we did not encounter any difficulty inserting the device into the rectum, we can anticipate how maneuvering the mounted robotic arm can be challenging, particularly in the proximal colon. Given the limited experience, the most suitable lesions for robotic-assisted traction are yet to be defined. Last but not least, although the cost of the robotic arm has not been established, this will need to be factored in when determining its overall utility. In conclusion, we demonstrated the use of a robotic platform that allowed real-time tissue manipulation and dynamic adjustment for traction and tissue approximation during closure. Future clinical studies are needed to further establish its feasibility, safety, and potential impact of this robotic traction device on ESD.